Welcome to the class. So today's topic is MBRRACE, that is UK Maternal Deaths and Morbidity Report 2021. What does the MBRRACE stands for? It is Mother and Babies Reducing the Risk through Audits and Confidential Inquiries across UK. Okay, so Mother and Babies Reducing the Risk through Audits and Confidential Inquiries across UK. That is the long form for the MBRRACE. And basically, this is the maternal death and morbidity report published in 2021. Okay, so we begin with our quote: "Master MRCOG with concept-oriented clarity." Okay, this particular topic is going to be very important for part 1 as well as part 2 examination point of view, because many questions will be asked. For part 2, there will be at least 2 EMQs and there will be 1 SBA or 2 SBA and 1 EMQ on this particular topic. Especially if you see paper 1 or paper 2, from question number 30 to 45, at that particular place you will get these kind of questions. So we begin with the definition of maternal mortality. So this MBRRACE UK uses the standard WHO definition with a specific time frame. The definition which is used by the MBRRACE is same which is given by the WHO. However, there is a little difference with respect to the time frame that we will discuss as we go in the slides. Okay, so maternal death is a death of a woman while pregnant or within 42 days, that is 6 weeks of the end of the pregnancy, from any cause related to or aggravated by the pregnancy or its management. It does not include accidental or incidental causes. This is the crucial definition for international comparison and for identifying deaths which are directly linked to the obstetric care. Okay, so here actually many questions are asked. So what are the different types of maternal deaths? Okay, so they'll give you the scenario. The patient has delivered at such and such week, and she is post delivery so many days, and this is the cause of death. How will you classify the death? Okay, so what are the different types of death you should know, and then accordingly you have to classify. Basically, there is a broad classification. What we know is a direct death and indirect death. Apart from that, there is something which is called as coincidental death, and there is something which is called as late death. Okay, so this all we are going to see now. So what is direct death? Direct death results from obstetric complications or their management. And the examples of these are hemorrhage, sepsis, preeclampsia, thromboembolism. So if there is any death which is related to this, then it is going to be direct. Okay, then indirect death. Indirect death, it results from pre-existing or new medical or mental health conditions aggravated by the pregnancy. Now, the examples of this are cardiac disease, epilepsy, COVID-19, etc. Okay, so as far as mental health is concerned, here mainly they are talking about the drug abuse, alcohol, etc., or the substance abuse. They are included. But per se, the suicide, okay, maybe secondary to the mental health, comes under the direct cause that we will see in the subsequent slides. Okay, then there is something which is called as coincidental death. Okay, so this results from unrelated causes. Death would have occurred anyway, even if she would not have been pregnant. Then also this cause is coincidental to the pregnancy. The mother would have died from that particular cause. So that is a coincidence. For example, there is a road traffic accident, homicide, or unrelated cancer. Okay, so these are coincidental deaths. Okay, then what is late death? So what we have seen in the definition of the maternal death by the WHO, they have considered up to 42 deaths, but MBRRACE considers up to 1 year postpartum. So late death, that is direct or indirect death, which is occurring after 42 days but less than 1 year postpartum, comes under the late death. Okay, so late suicide, delayed complication from birth injury. Okay, so there may be some PPH which is managed, but she has ended up with organ failure. Somehow she is prolonged, but if the death happens after 42 days, then it comes under the late death. So it may be late direct death also. Okay, then pregnancy associated. Okay, any death during pregnancy or within 1 year of its age. So this actually pregnancy associated is an umbrella term which is encompassing all these terminologies, that is direct, indirect, coincidental, late death. Okay, so basically they are interested in knowing whether you know the concept of late death or not, whether you are able to classify the cause as a direct or indirect. Okay, so these are the examples of the direct causes. These are the examples like any medical illness, maybe cardiac disease, epilepsy, COVID-19, etc. These are indirect deaths because they are aggravated by the pregnancy. Okay, they may be pre-existing or they may be newly diagnosed during the pregnancy, but their condition gets worsened because of the pregnancy status. Okay, so these are the kind of questions, and especially EMQ type of questions they are asking. Okay, so another thing is that what are the key messages from this particular maternal mortality report? So they have found that 191 women died during or within 6 weeks after the pregnancy between 2017 to 2019 in the UK. This occurred among 21,73,810 maternities. Okay, the maternal mortality rate was 8.8 per 1 lakh. Okay, so this figure you can remember. So it is less than 10, 8.8. Okay, so 8 to 9, somewhere between this is the maternal mortality rate. No statistically significant change in the maternal mortality compared to the previous 2010 and 12 report. Okay. So this is the 8th annual MBRRACE UK report on maternal deaths and morbidity. So this particular report also takes into account the morbidity also, not only the maternal death, but this report is about the morbidity during the period 2017 and 19. So it covers the death during or up to 1 year after the pregnancy in the UK and Ireland. Okay, so that is the late death. Okay, are also included in this particular report. So it includes the confidential inquiries into mental health related deaths, venous thromboembolism, homicide, malignancy, and it also includes morbidity inquiry into care of women aged more than 45 who gave birth. Okay, so this is one of the peculiarity. The elderly women more than 45 years, the morbidity inquiry is one of the feature of this particular MBRRACE report. Okay. Now, what is the report scope? So there were 495 maternal deaths during or within a year post-pregnancy. They were analyzed, and there were 37 women aged more than 45 who were reviewed in depth for morbidity inquiry. Okay, so these figures they will not be asking. So just for the information purpose, I am discussing. So report structured as 7 standalone chapters, and these chapters will cover oral maternal death surveillance, older maternal age, then mental health and multiple adversity, malignancy, and venous thromboembolism. So the emphasis is given on all these. So your questions in whole of your obstetrics may be from different modules, and there will be a lot of emphasis on these particular aspect. Okay, so different methods they have identified. So basically multidisciplinary review of panel is done. Almost 10 to 12, 15 experts will be there. They have identified the or they have gone through the medical records of the patients to form these particular. Okay, so they have not only gone through the reports, not only the multidisciplinary review has been done, but they reviewed the care. Okay, and this care is then assessed against the national clinical guidelines like NICE, Royal College. So whether the care which was given was adequate and appropriate or not, that has also been identified or assessed in this particular report. So findings inform recommendations for care improvement. Okay, so and all healthcare professionals who are involved in care of women should know these recommendations. Okay, now what were the key findings of this particular? So overall the pregnancy is safe in the UK. Okay, then what are the leading causes of maternal death? In the indirect deaths, these are indirect. The heart disease, epilepsy, stroke. So among the indirect causes, heart disease is the first, or overall also the heart disease is the leading cause. This can also be asked as a SBA or EMQ. Okay, so heart disease is the first. Then neurological cause. So in the neurological cause comes epilepsy and stroke. Okay, then coming to the direct causes. So what is the leading direct cause? The thrombosis and thromboembolism, and not the postpartum hemorrhage. Remember, PPH, preeclampsia are not, these are also direct causes, but the leading direct cause is the thrombosis and thromboembolism, and indirect cause is the heart disease. Okay, first cause. Okay, and among the direct and indirect, which is more common? Can anyone tell me which is more common? Whether direct is contributing more or indirect is contributing more for the maternal mortality? Yes, anyone?
Indirect.
Yeah, indirect is around 51%, almost same both, but there is a little dominance of the indirect causes. Okay. Then cancer is one of the frequent cause of death between 6 weeks to 1 year post pregnancy. This also we will see uh, that between 6 weeks, that these are the late death. Okay, so in the late death, the cancer is one of the important cause for the mortality. Then suicide is the leading direct cause, pregnancy related cause of death in the first year of the birth. Okay, so if they ask you what is the most important cause of maternal death after 6 weeks, if they ask you this, then there is a question whether to select as a cancer or whether to select as a suicide. Okay, because both are common. Okay, then in the subsequent slide we'll see what they have given in a diagrammatic form, and then we'll make a conclusion. But if they ask you about the leading direct cause of maternal death in the late period, then suicide becomes the answer. Okay, so suicide is the leading direct cause of death in the first year. Okay, if they don't ask about the direct, but if they ask you about the overall, what is the important, then the cancer might be the answer. Which one to select, that we'll see in the end. Okay, and what are the emerging themes from this particular report? These themes, if you go through this particular report, you will understand that it is a risk is a dynamic. Risk is not at all constant. The risk changes over a period of time during the pregnancy, and that is why the risk assessment is periodic. Say for example, venous thromboembolism, the risk is always ongoing risk. So you have to assess antepartum, intrapartum, postpartum. You need to assess frequent. Okay, so the risk is a dynamic. Second, clinician is a focus in this particular. Okay, so the burden is not given to the patient or the pregnant woman, but it is the clinician responsibility to guide and arrange for the services. Okay, then what is the key message? Treat pregnant and recently pregnant women as non-pregnant unless there is a strong reason not to do so. Okay, so every pregnant woman should be, most of the time the clinicians are cautious, the patients are cautious for taking any treatment apart from pregnant status. Okay, so if all these indirect causes are not related to the pregnancy, they are associated with the pregnancy, either pre-existing or, and then if they are not treated, may lead to mortality. I hope you have understood the key message of this particular uh, report. Okay, now this particular slide is going to be very important because there will be lots many figures, and these figures can be asked as a SBS. Now they have found that there is inequality in maternal outcomes. Okay, so there is a ethnic disparities in the maternal death rates. The white women have the least maternal death, that is 7 per 1 lakh. Okay, so white women 7 per 1 lakh, Asian women 12 per 1 lakh, mixed ethnicity 15 per 1 lakh, and black women 32 per 1 lakh. Okay, so generally they can ask you about black women because it is highest, and Asian can be asked. Okay, remember the list to the highest. White 7, then Asian 12, mixed 15. So these two are double of this, and this is almost 4 times. Okay, so black women will have 32 per 1 lakh. Then there are socioeconomic gaps. Women from deprived areas continue to face higher risk. Okay, so ethnic and social inequalities in the maternal death has been reported. Black women are 4 times more likely to die in pregnancy than white women. They may give you some sentence also in the SBA. Which sentence is correct? Black women has got equal chance of maternal death like white women, maybe 2 times, 3 times, 4 times, 5 times, something like that. And you have to select appropriate answer. So the black women are 4 times more likely to die in pregnancy than the white. Okay, Asian women are almost twice as likely to die compared to white women. Or they may give you these 3-4 sentences and will ask you which one is not correct. Okay, which one is wrong. Okay, so black women 4 times, Asian women 2 times as compared to the white women. Okay, clear this much? These figures you will remember.
Yes, sir.
Okay, so note these figures down at some place in your notes. Okay, women in the most deprived areas have double the risk of dying compared to those in the most affluent areas. So most deprived population, the death rate is 14 deaths per 1 lakh, while the least deprived is around 8 deaths per 1 lakh. Okay, so 17% of women who died were involved in the social services. So 17% of the women which have expired or died, they were already in the social, getting some social benefits of social services, so they had some issue already. Okay, and 8% experienced multiple disadvantages like mental illness, domestic abuse, substance misuse, though this is likely to be underreported. So 8% were had multiple diseases. So not only the medical cause or the obstetric cause, but there were multiple disadvantages. Okay, so mental, domestic, substance abuse, etc. These causes were also there in 8% of cases, though the underreporting is known to happen about these particular conditions. Okay, then better data collection on complex social issues is urgently needed. Now, as I told you, they have taken into account the morbidity, especially in elderly mother. So a lot of questions you can expect on this particular. Last time we had a special talk on the elderly women induction, and many topics from the obstetrics we have covered, especially with the elderly mothers. Okay, so what they are saying about the pregnancy at advanced maternal age: pregnancy risk increases with the maternal age. So there is a higher mortality, pregnancy loss, and complications. Fewer than one third received care according to the medical guidelines. So whatever care which they are supposed to receive, only less than one third patients have received such kind of care. Few women planning late pregnancies had documented discussions on the health risk. Okay, so those patients, especially elderly patients, need to have pre-pregnancy counseling, appropriate planned antenatal care, intrapartum care, and post-pregnancy care also, including the post-pregnancy counseling. But if you see the documentation, only few women had this kind of documentation. Okay, those who were planned the pregnancies at latter age, and average age of first time mothers is increasing, and that is why this particular topic is going to be very, very important. So apart from this, they have analyzed the quality of care and systemic issues. So what are the system related issues which were responsible for maternal death? So in 37% of maternal deaths, better care might have changed the outcome. So if the care would have been given in a better manner, 37% of patients would have had a different outcome. That is what the report says. So almost, one third of maternal deaths could have been prevented or could have had different outcomes, provided the care would have been changed. Okay, then structural and cultural biases that we have already discussed what exactly is there, and issues of inequality and disadvantages are persistent and unaddressed every after year. Okay, so these are the basic some messages from this particular thing. Then there are certain advices for the older women before the pregnancy, during the pregnancy, and after the pregnancy. Okay, so before the pregnancy, aim for healthy weight, take folic acid, continue coexisting medications. Unless most of these females will have some or the other medical condition, they will be on some medication. So unless advised by the doctor, they should continue to take the existing medications. Discuss the health risk with the doctor, especially if they are planning IVF, and avoid multiple births, especially twins, etc. Okay, then during the pregnancy, continue folic acid and medication. Expect more scans and diabetes testing. After the pregnancy, monitor for blood clots, that is venous thromboembolism, there we need to assess, and mental health issues we need to check, and continue medication and seek help when needed. Okay, then they are talking about the mental health and multiple adversity in pregnancy. Okay, so when we have seen about the elderly women, then next topic is about the mental health and multiple adversity in pregnancy. What does this particular report says? Mental health is a leading cause of maternal death during pregnancy and the first postnatal year. Many women who died from suicide or substance misuse also experience multiple adversities like abuse or poverty, etc., etc. Improvements in care could have changed the outcome for almost 67% of women who died by suicide, and 29% who died by substance misuse, and 18% who died by homicide. So just improvement in the care which is given to the patient, if that is improved, 67% of the women who have died because of suicide, that could have been prevented. Okay, substance misuse, 29% would have been prevented. Okay, so these were the important things. And postnatal period is a high risk time requiring immediate risk management, and teenage mothers need special attention regarding mental health support. Okay. Now, what are the red flag symptoms for women and families? So, is there any new or disturbing or anxious thoughts which is not felt before? Suicidal thoughts or violent self-harm ideation is there? Persistent feeling of incompetence or disconnection from the baby, sense of worsening mental health. So these are the things one should look for. Speak up early if you notice these symptoms in yourself or someone else. Okay. Now, next important topic is a cancer care. So we have seen elderly mother, then we have seen about the mental health. Now they are talking about the cancer care in pregnancy. So what key facts they have mentioned? Pregnancy does not protect against the cancer. It can still develop. Symptoms should never be ignored or delayed because a woman is pregnant. Investigations like X-rays and many cancer treatments are safe during the pregnancy. Early planning is essential if cancer is diagnosed or suspected, and always multidisciplinary care, which is crucial, involving obstetricians, oncologists, and other specialists. COVID-19 may have caused delays in cancer diagnosis, increasing the importance of vigilance. So, diagnosis and treatment should be continued even during the pregnancy unless contracted. So apart from that, next is a thromboembolism. Okay, so mental health, cancer. The next is a thromboembolism. So what they are saying about thromboembolism, this year's report highlights deaths from venous thromboembolism, especially in young, extremely obese women. And the high risk factors for VT will include older age, overweight, obesity, recent surgery, or cesarean. So these were the high risk factors for the development of the VT. And blood thinning treatments such as injections, tablets, they are safe in pregnancy and breastfeeding. Complete prescribed treatment without gaps. So patients should take the treatment, whatever treatment is given, they should take it continuously without any gap, and generally either 1 week, 10 days, or 6 weeks, depending upon case to case. They have been advised these blood thinning agents, they should continue it properly. Risk may change during or after the pregnancy, especially post cesarean or C-section. Okay. Symptoms to watch for: cough, pain, severe breathlessness. These symptoms one should watch for and report symptoms urgently, even in early pregnancy also. Okay. So up till now we have discussed about what were the common causes and the trends. Okay. Then now we will see what they have mentioned about this particular thing. Most of the things we have already covered, like there is no statistically significant decrease in the overall maternal deaths from the previous report. Then good care is seen only in 17% of cases, while 37% could have had improved outcome with better care. Okay, so 37 overall 37% cases would have different outcome if the better care would have been given. Then this we have seen, black women have got 4 times higher chance than the white women for the maternal mortality. Asian has got 2 times higher, okay, compared to white women. Urgent action is needed to address these racial disparities. Social disadvantage: 8% of deaths involved in women having severe and multiple disadvantages like mental illness, substance use, then domestic abuse, etc. Then leading cause of maternal death: indirect cause is the cardiac disease, that is the most common oral cause. The neurological cause is the second, that is epilepsy, stroke. Okay. Then leading direct cause is a thrombosis or thromboembolism. It is an important cause within the first 6 weeks. Then maternal suicide is the leading cause of late maternal death up to 1 year. Okay, this is the late direct cause. Okay, late direct cause up to 1 year. Okay. Then they have given some summary, uh, and there are recommendations for professional organizations. There are some recommendations for policymakers, planners, and service managers. There are some recommendations for the health professional. Okay, this particular slide we will see at the end in a tabular form so that you will understand it in a better way. Okay. Now, they also mentioned that there is a guidance which is already existing, but we need to strengthen it, or it needs better implementation. Okay, so for example, care of older mother. Okay, there should be maternal assessment before assisted reproduction. Serial USG plus Doppler should be done after 40 years of age, or if there is any major risk factor. Aspirin 75 to 150 milligrams should be given for preeclampsia risk from 12 week onwards, and they should be screened for GDM all high-risk patients should be screened. And when there is a babies or the mothers at a period of viability, questionable viability, what you can say, doubtful viability, extreme preterm birth, less than 27 weeks, then we need to respect the parental wishes in shared decision making. Okay, so in my previous lecture also, I have always emphasized on the shared decision making. Okay, so this particular thing is very, very important in part 3 when you talk with the assessor or the role player, and whether you are giving this particular option of shared decision making, you are giving all information and let her decide what exactly she wants to do, and that is what is the shared decision making. Okay, use once daily antihypertensive postnatally whenever possible, and offer contraception before maternity discharge. So these are the existing guidance, but it needs better implementation. So there is a scope for the further strengthening of these particular services. That is what the report says. Then care of the women with mental health issues. Basically, we have seen what exactly the role of mental health issues is there. But what the report says, there has to be coordination between the GPs and the maternity services, and there should be joint functioning of these particular, because mental health services, maternal services, and the GP, all these should work together to reduce this maternal deaths due to mental health. So mental health services must inform maternity services of the risk. Then what are the red flag signs? Violent self-harms, estrangement from the baby, severe maternal incompetency. These were the red flag signs. Then if there is a psychosis history, then your patient is very high risk, and it needs individualized assessment. If there is a loss of child, then the patient is very vulnerable for the development of the mental health issues. So extra monitoring is required. Decision on psychotropic medication, we need to balance the risk is to benefit ratio and take the decision appropriately. Release records of maternal deaths to MBRRACE UK for appropriate reporting, and ask sensitively about the domestic abuse at booking and first private opportunity. Okay. Then for the care of women with cancer, postpone pregnancy advice tailored to treatment and prognosis. So this should not be uniform, the postponing the pregnancy. It should be tailored to the treatment of that particular patient, of that particular stage of the malignancy, and the decision should be taken. Early senior maternal medicine involvement for admitted women. Treat pregnant women same as non-pregnant women unless contraindicated. If there is a cervical cancer suspicion, urgent referral within 2 weeks. Okay, urgent referral is within 2 weeks, the patient should be referred. Remote consultations only if appropriate, otherwise it is a face-to-face consultation should be arranged. And do not routinely recommend early delivery for breast cancer, and balance chemotherapy needs. Okay. Then what about the thromboembolism? So pre-pregnancy counseling for women with previous history of VTE, simplify and standardize VTE risk scoring tools, structure management plans for anticoagulated women across perinatal care, prioritize consultant review for women on anticoagulation awaiting induction, and start unfractionated heparin promptly in high-risk pulmonary embolism and thrombolysis if indicated. Okay. So these actually the mental health, elderly women, thromboembolism, there may not be question from the members, but otherwise also from the respective guidelines, there will be questions on a lot of questions. Okay. So same whatever we have discussed, the message for the professional organizations will be unified guidance for older women. Okay. So there are separate guidance, pre-pregnancy, intrapartum care, induction, etc. So those are to be put together, and there should be single source guidance for the older women. Then IVF embryo transfer guidance should be there. Cultural changes for contraception, pre-pregnancy care, and guidance on imaging in pregnancy should be there. For policymakers and planners, there should be clear pathways for perinatal mental health, inclusive of mental health services, adequate to specialist capacity, and multidisciplinary incident reviews, and standardized VTE risk tools should be there. For health professional, we have already seen that don't delay aspirin. So these are the preventive measures should be given to these women. Ensure pre-pregnancy and post-pregnancy counseling. Consider stressors in mental health assessment. Early review of psychotropic medication. Expect recovery in the recurrent illness. Avoid overburdening relatives. Support substance misuse cases, etc., etc. So the health professional should be aware of all these things. Okay. Then for older mother, the existing guidance is pre-RT assessment should be there. serial ultrasound and Doppler, that is what we have seen. Aspirin for preeclampsia risk, DDM screening, this also we have seen. Okay, and at extreme preterm, it is a shared decision making. Once daily antihypertensive postnatally. For mental health, we have already mentioned that there has to be good collaboration between the maternity services, mental health services, and the general practitioner. Okay, if she is a case of psychosis, she is a high risk. Okay, support after child loss, careful psychotropic medication review should be performed. Okay, and record should be submitted to MBRRACE in case of maternal death, and screen for domestic abuse, especially in these patients. Okay, for cancer, individualized pregnancy delay advice, early senior review in illness, treat same as non-pregnant unless contraindicated, urgent referral for cervical cancer suspicion, and prefer face-to-face than the what you can say online or indirect interview. Okay. Breast cancer, avoid early delivery unless necessary. For VT, pre-pregnancy counseling, plan for prior VT should always be there. Simplify VT risk scoring. This also we have already seen. Okay. Now these are couple of further slides which are there, and graphs are there. From there they can ask you the questions. Okay, so uh, these are the indirect causes of the maternal death, and these are the direct causes of the maternal death. Okay, so solid bar indicate indirect causes of death, and hatched bars indicate the direct causes of death. Okay, so we have mentioned that leading cause is the cardiac. Okay, so this is the indirect cause, highest. Okay, cardiac, followed by the neurological, in which you have stroke and epilepsy. Okay, then sepsis, there are two. Okay, sepsis can be direct also, and it can be indirect also. Okay, direct sepsis will be the genital tract related sepsis, and indirect sepsis will be like a influenza, pneumonia, others. Okay, so these are the indirect sepsis. So role of direct sepsis, genital tract sepsis, and other pregnancy related infections are these. Okay, and these are the indirect sepsis like influenza, pneumonia, etc., etc. Then rate for suicides is shown as a direct. Okay, so can you see suicide here? This must be because it comes under psychiatric. In the initial second or third slide, we have spoken about this psychiatric. Okay, there it was mentioned about as indirect, but not all psychiatric conditions will be indirect. Suicide becomes the rate for suicide is the direct shown in the hatch, and rate for indirect psychiatric causes, that is drugs and alcohol. So these are the suicide, and these are the drugs and the alcohol. Okay, rate for indirect malignancies, that is breast, ovary, and cervix. Okay, so rate for indirect malignancies, where are the indirect malignancies? So these are the other indirect. Okay, early pregnancy, and these are the malignancies. Okay, so these are the malignancies. Okay, rate for indirect malignancies, breast, ovaries, and cervix. Okay, so this is what about this particular graph. Then coming to this pie diagram, this shows about the maternal mortality proportions by ICD-MM classification. So if you see here, the non-obstetric complications contribute around 54%. Okay, non-obstetric complications contribute around 54%. Okay, and if you see the obstetric related causes, it is abortive outcome, then hypertensive disorders, obstetric hemorrhage, pregnancy related infections. So this is less than 50%, while rest of the causes are the indirect causes. Okay. Then causes of death among women who died between 6 weeks and 1 year after the end of the pregnancy. Here is the answer to our previous discussion. So if you see the between 6 weeks and 1 year, if you are asked about the direct cause, then the suicide is 18%. You look at all these percentages. Look at all these percentages. Sorry. So you will find that highest is 19%. Coincidental malignancy. Okay, coincidental means even if the patient would not have been pregnant, but that malignancy would have been present, she would have died. Okay, so this particular cause is 19% between 6 weeks and 1 year. And if you see the suicide, that contributes to the 18%. So this can create a confusion while selecting the answer. Okay, rest of the cases are less than 19 or 18. Okay, so if it is they are asking about the direct cause, it becomes the suicide. If they are asking the overall, then it might come as a coincidental malignancy. Okay, is it clear?
Yes, sir.
Is it clear? Yeah. Okay. This I am telling you from the graph which is given in the MBRRACE report. Okay. Then selected characteristic of women who died from direct or indirect causes between this particular period. Okay. So these were the obesity, BMI more than 30, mental health. If you see that pre-existing medical illness, okay, again high. Okay. So these are the indirect causes. Okay. Then second is this, did not receive recommended antenatal care. Okay. So even that was one of the major cause for the maternal death. Okay. So key messages for the care of the older mother. This we have seen. There should be single guidance source, collate existing recommendations into one definitive guideline for older women, both assisted reproduction and spontaneous conception also. IVF and embryo transfer, develop specific guidance for single, so promote single embryo transfer for these women. Okay. Preventive care like aspirin, etc. we should emphasize, and there should be screening for GDM. Okay. And pre-pregnancy as well as post-pregnancy counseling is important. Then existing recommendation strengthening also we have seen. Priority assessment for medical screening prior to the assisted reproduction. Then folic acid supplementation for BMI more than 30. Advise 5 milligrams of folic acid from 1 month preconception until the end of the first trimester. Okay. Ultrasound surveillance, Doppler is important. Serial scan, growth scan is important. Then aspirin prophylaxis that we have discussed. Okay. Then screening for the diabetes, BT risk assessment, and always give the information, provide clear and individualized antenatal information. Extreme preterm, it is a shared decision making. Preeclampsia, postpartum care plan should be explained. Document follow-up provided, and BP monitoring schedule should be explained. All these things are to be done. Postnatal antihypertensive, prefer single dosing, and contraception post-birth should be offered prior to the discharge. Okay. So that finishes the today's topic of MBRRACE. Thank you.